Get going.
I remembered to record.
Great. Yeah. So welcome to the Community Engagement Speaker Series. My name is Linda Sprague Martinez, and I co-direct the Community Engagement Core of the Boston University CTSI with my colleague, Tracy Battaglia. Tonight, we are so thrilled to have with us two leaders here at our own Boston University, Boston Medical Center community, and they are going to be speaking with us on formalizing equitable partnership agreements with communities, lessons learned from subcontracting with partners in 16 Massachusetts communities, which gives me a little anxiety to think about subcontracts with 16 distinct, unique communities. So I am so pleased to have with us today Carly Bridden, who is the project director for the Healing Community Studies. And I know that's just one of her many roles in the addiction medicine unit, but as well as Shruti Shantharam. Sorry, Shruti, I realized I never said your last name before. Sorry. And then who is the associate director of the administrative and community operations with the Healing Community Study. And so we will have an opportunity to hear from both Carly and Shruti this evening. We will then have some Q&A where we'll have some questions that have been sent in advance and that we have, as well as the audience will be welcome to ask questions as well. So with that, I'm going to go to you can go to the next slide, Dima. Our objective for this evening is that we will, after hearing this presentation, begin to understand and learn practical steps and tips for developing partnerships and partnership agreements with communities. How is it that we formalize our partnerships in an administrative sense? So with that, I'm going to hand it over to Carly and Shruti. We have you on another slide here.
Okay. Well, thank you, Linda, and thank you all for joining us on a 5 o'clock on a Thursday. I'm impressed. So as Linda said, I'm the project director for the Healing Community Study. I'm based at Boston Medical Center in the Clinical Addiction Research Education Unit, and I do spend time between Crosstown and Shropshire. We were just talking about that because the study that team we had to hire for this new study was so big we couldn't fit on the main campus. But I think Dima is going to run the slides for us. We have just a few slides just to introduce the study, so you have a little bit of the context, and then Linda and Dima will, I guess, facilitate like questions and things. So we'll try not to go too far before you can jump in with questions. So welcome. So the grant study is called the Healing Community Study. And as Linda said, I'm going to present with Shruti, our Associate Director for Community and Administrative Operations. Next slide. So the Healing Community Study, it's funded by NIH, and it's aimed at reducing opioid overdose deaths. There's a lot more that goes into it, but that is really the laser focus that we have. NIH awarded 4 different research grants in 4 different states. So all 4 states, we had submitted separate grant applications, had agreements from our community partners on what we were proposing. And then when we got funded, we all had to come together and create one unified protocol. So I would say that was our first challenge, because we all wanted to hold true to the promises that we had made to our community partners and what we told them that they would be getting into. And so that was a challenge number 1, I think. So I'm not going to go too much into the history of the grant, but you can go into healingcommunitystudy.org to learn more about it. So just focusing on the map of Massachusetts, we had 16 communities that we work with. It was a randomized controlled trial. So 8 of them are what we call wave 1, which is the intervention group. And then the other 8 are in wave 2, which is, the traditional control group, but it's a sort of a waitlist control. So they will get the intervention after wave 1 gets the intervention. And you can see here that the orange coloring is for our wave 1 communities, and the solid coloring is for urban. So, we have a definition of what's urban. We were a little surprised that North Adams was considered urban, but based on what definition we used, that's how it landed. And then in rural are the check pattern. So you can see here a distinction is a lot of the wave 1 communities are more on the eastern part of the state. That was another sort of issue that came up pretty soon in the study that we had to address in the randomization. So I won't name all the communities, but I don't know if you'll get these slides afterwards. You can see them. Next slide. So the goal of the HCS, the Healing Community Study, is to reduce opioid overdose deaths through implementation of evidence-based practice strategies. So the premise of the funding opportunity was that we have proven methods that can reduce opioid overdose deaths, but they're just not getting out across and being utilized. So the focus of this grant was not to test whether medication worked or whether Narcan worked. Like, we know those things work when used and accessible. So the goal of this study was to get those things out into hands of the community members and the people at risk and those friends and family members of folks that could facilitate access. So the focus of the three evidence-based practices that we utilize are increasing access to overdose education and naloxone distribution, increasing access to medications for opioid use disorder. And I'd say in Massachusetts, that's a real central focus of our programs, and increasing safer opioid prescribing and dispensing practices. Next slide. So those are the three sort of evidence-based practices, but how are we going to get those from the academic medical centers to the communities? So that's where the intervention comes in. And a process was developed called the Communities That Heal intervention. It was based on another community intervention called the Communities That Care intervention that I think was mostly focused on prevention in youth, but it's a phased process. And so we adapted that for this purpose. So the Communities That Heal intervention is a community engaged intervention to develop a data-driven community response plan, we call them the action plans, to deploy evidence-based practices across multiple sectors, so like criminal justice, healthcare, harm reduction, to reduce opioid overdose deaths through a phased planning process. So ours is it's a 6-phase process with an additional 7th phase for sort of preparing. We call it phase 0. But so the 3 pillars of the intervention are really community engagement, opioid overdose reduction continuum of care. And that is more the clinical programs like the Narcan and the medication and the safer prescribing, and then a communications campaign to not only address stigma, but to build awareness for the issues and for medications and different treatments. Once we were able to build up the programs to let folks know that services are available. Next slide. And a real big pillar of the research study. It's technically not part of the intervention, but it really is part of the intervention, but it's a requirement of the grant to advise this to the research study to have a community advisory board. So our community advisory board has 1 member from each of the 16 communities. So it has, mixes the wave 1, the control and intervention group into an advisory board. And then we also had started off with 8 statewide sort of experts in different fields in Massachusetts. That were added with the community specific CAB members. So they provide guidance on the overall direction of the project, they inform decision-making, they advise on design and implementation. And as I said, we have representation from all 16. I don't know, is this where I take a pause? Yeah. So that's sort of the background and overall high-level view of the research study.
Great, excellent. So I guess now we're, I think, jumping into kind of the Q&A. So we give you a sense of the overview of the study. And then one of the questions that we had was really, who are the partners that you're working with in each of the communities? And if you could just provide us with a little bit of a snapshot of who those partners are, what are the agencies, how do you bring them to the table? We want to know it all.
I'll pass that to Shruti. She does have a couple of slides. I don't know if it's helpful to start with those that kind of give the numbers, but I'll hand that question to Shruti.
Okay, great.
Yeah, I think our slides perfectly speak to that. So if you want to pull that up, we can. Yeah. So this is a little bit of a snapshot of our fiscal agents. So I'll start by defining what that is because we use a lot of HEAL jargon. So fiscal agents are organizations within our communities that facilitate funding to our community-based partner organizations who are actually implementing the selected strategies. So this is actually a key example of this being a community engagement driven study, is that we wanted to have these fiscal agent partners within our community for the funding to flow through them rather than directly from our institution into the community partners. So our fiscal agent partners, one in each community. We have 2 community health centers. We have 4 nonprofit service agencies, 1 health department, and 1 university/institution. I believe, and Carly, you can correct me if I'm wrong, the original aim was to work with all health departments, or that was the original approach. And then over conversations, a lot of them didn't have the bandwidth, or a lot of them felt like a different organization in the community would be a better fit. And so a lot of these decisions were made kind of working with community partners and key stakeholders to identify the right fiscal agent partners in each community. You can go to the next slide.
I will say that our fiscal agents, we had actually identified them when we wrote the grant with the help of the Massachusetts Department of Public Health Bureau of Substance Addiction Services, because they provide community fund. They had these community coalition grants. And so we were going to work with the institutions that had those grants, and a lot of them were health departments, but some of them were the sort of service agencies as well.
That's perfect. Next slide. So this is a little bit, Linda's heart rate's going to go up. This is a little bit of a sneak peek at our actual total amount of subcontracts for HEAL. So we hold 13 subcontracts with our academic partners. We have 8 Wave 1 anchor agencies. So our anchor agencies are office-based addiction treatment programs within our communities. We have 8 fiscal agent contracts. We have 8 fiscal agent contracts for Wave 2 as well. And then we have 6 direct contracts with community-based organizations due to limitations of third-tier subcontracting regulations. So what that is essentially, depending on what the scope of work is, there are certain things that have to be held closer to the original grant recipient, which is Boston Medical Center in this case. So in the case of our study, any organizations looking to purchase vehicles for vehicle-based programs had to have a direct contract with BMC and be a direct subrecipient of our contract. So they were able to purchase a vehicle and kind of have ownership over the process. And we were able to facilitate that through direct community-based contracts. And then the next slide. Yes, this is a look at the process a little bit. So the first part of our process, which is what Carly talked about, is we work with community stakeholders. And originally in our grant, we had worked with the Bureau of Substance Use. So in Wave 2, we've been working closely with community stakeholders to identify agencies who would be good partners within the community to facilitate the flow of money. And we work directly with the agency to determine if they can meet the requirements of subcontracting with BMC. I've added a caveat here that we have definitely had instances where we've determined together that the agency cannot meet the requirements of BMC, and we've had to go back to the drawing board to identify a partner. This has been for a lot of reasons, not necessarily because of the requirements, but COVID threw a big wrench in a lot of community organizations' bandwidth to take on work like this, and so we definitely had to get creative about which organizations were able to do this work. From there, partners complete initial paperwork. So often this is paperwork that might be required for an advance payment, a vendor PO, auditing purposes, things like that. And after BMC reviews this paperwork, we draft a contract that's then signed by both parties. And this can take a lot of time. So this can.
Can I ask
Sorry,
a
Linda,
question?
you say something?
Can I ask a question, Shruti? I wondered, you talked about good partners and that would allow for money to flow. Like, what were I think 2 things. So what were those criteria? What do they look like? And then how do you have those conversations with communities? Because sometimes that can feel like, what do you mean I'm not a good partner? Or how do you actually kind of approach those conversations? Because they're difficult.
Yeah, I think mainly I ask Linda what I should say most of the time, and Linda helps me navigate it. I think what we've learned, firstly, I will say what we have learned to be a great partner has 100% changed in the time that even I've been on the study, which is not the full amount of time of the study. But I think what we have learned, at least as the best approach, is to lay out every scenario we can think of that the fiscal agent would need to step in, or the fiscal agent plays a major role in. So the best case scenario is for us to say, here are all of the things we can think of that may come up that would need your involvement, we would need your partnership with. And we kind of let that drive how both the partner and we perceive like the ability to do this work, rather than like us making a determination. I think it's a little bit more about laying out like the gamut of scenarios that might come up and seeing how they react to it and how they think through the process that might come up. Carly, do you think that we've handled it differently in different places?
Yeah, I think what you're talking about is definitely like the lessons that we've learned, we're putting into practice for wave 2, which is kind of going on, like we're doing this again right now for wave 2. But in wave 1, it was tricky. I think at a minimum, BMC Grants Administration has like a checklist, and that wasn't to say they said like, no, we can't. It would just put somebody in a high risk category. And again, we wouldn't go to someone and say, you're a high risk, subcontract. So it was really like, I don't know if anyone here remembers Nikki Spencer, who used to be part of the CE, like I would have her on all the calls with me, because we really needed, we wanted to be tactful and do it right and not, upset. We wanted to use the right language and the right tone. So definitely relying on our CE friends, but also at times we could rely on BMC. So we, the grants, it's out of our hands, it's institutional requirement. That was, a tactic that we could use sometimes when it was a little bit, not a positive message that we had to give. I think also just being very clear on like what was required and kind of trying to get them to see that this is what's required, and do they want to be involved with it themselves, and having to really stick firm. We had to know what line we were okay to be flexible and where we couldn't, and trying to get them to see that line, I guess, without having to be the ones to do the breaking up. But there was definitely a couple of times where we had to break up.
Sounds like transparency, like you all were really transparent in terms of what you shared. I also wondered, Shruti, you mentioned when you were going through, like, would an organization need to have, would they need to have an advance payment to be able to do the work? Can you talk a little bit about what that is? What was like just a little bit about that process?
Yeah, I think that was a great lesson learned. Again, our grant is a reimbursement-based grant, which means majority of the work done is reimbursed rather than paid up front. So that means that in our communities, all of the work that they were doing, they would have to front the money for, and then we would have to reimburse them after the service had been rendered. But because we wanted to work with a variety of organizations in the communities that the communities felt good about, this meant that different types of organizations had different operating budgets. So the best, like, two ends of the spectrum I can give you is we are working with an institution, which is a university in our project, and they have a great operating budget. So for them, spending $20,000 in a given month and then being reimbursed by Boston Medical Center is not a huge inconvenience. However, we're also working with some really small social service agencies. And so for them, spending $20,000 and being reimbursed by us is really inconvenient and really difficult. And so what we had to do is work with our wonderful grants administration team, as well as BMC leadership, to ask for an exception to do these advance payments. And what that allowed was for us to essentially create these like escrow accounts that the fiscal agents could use, especially these smaller organizations, so that they were able to spend down from this pot of money that we had given them in advance of a service being rendered. And we would still collect the same backup documentation and invoicing, but it would allow for them to do the work without the burden of these massive invoices hitting their operating budgets.
I just want to jump in there and make a plug for being partners with other departments in your institution and not seeing, grants administration or the IRB as like, on the other side. Like, they're there to help support the research. And so I think we hadn't, up until this study, maybe hadn't had the experience where we had say this. I think it was just really helpful for us to be very communicative with the grants department. And because of the size of this grant and the publicity, we had weekly meetings, with folks. And we had, I think just knowing that they're there to help and to support and to open that communication, they can come up with ideas that you never thought of. And they have that, the ability to make exceptions and think of things. So just put that out there.
Great point. Great points. I have more questions, but I want to open it up also in case members of the audience have specific questions based on what they've heard so far. So I can pause for a moment. Are there any questions? Okay, don't worry. I'll come back to you, audience. But for now, I'm going to jump back into my questions around really some of the challenges. You've both alluded to different challenges that have come up along the way. And I wonder if you can talk about some of the challenges, whether it's on the institutional side or on the community side, or what are some of the things you've seen in developing partnerships and how have you overcome them?
I'll jump in with one. I think on our end, because we were building things up and trying to hire staff and building processes while we were trying to make relationships and get contracts in, things were really slow on our end. And so it was that was a problem, that we couldn't move fast enough. And I think, sometimes there's nothing you can do, but what you can do is just be as, open and communicate with your partners, not replying to an email for 2 or 3 weeks. That's within your control. You need to not let that happen. But if things, if you can't get to something, you just need to know. And one thing that we are trying to be better at is just to simply reply to an email to let somebody know, I got this, I'm working on it, I'm trying to get you the right answer, and I'll get back to you. Rather than trying to get the answer and then, not getting back to them for 2 weeks. So that, I think that the communication was one thing that can help, in a number of different challenges, but ours was sort of bandwidth and trying to move as fast as we could.
Yeah, absolutely. Everything Carly said. And I think the wonderful thing, as well as the challenge of our study, is that we have really innovative partners and communities, but they came up with things that I don't know if our grants administration team had ever been asked for a grant to pay for, or let alone be a part of. So things like vehicles to get patients to appointments for medication, vehicles to actually take medication to patients, literal opioid treatment programs, so building facilities. So these are all things that I think were new to the world of federal grants that we really had to work with them. And this is where what Carly said is 100% right, is viewing your grants administration team and others as your partner is the best way to get this done, because they were able to help identify. And I think this is a big lesson learned for me personally, is you really do have to go out of your way to communicate why this is important to the essence of our study, and not just assume that others are going to understand that, because this was really integral for us to honor our commitment to the communities and make sure that the ideas they came up with were something we could execute on. And so communicating all of that to our partner departments was the only way for us to actually get it done and to work with them on it. So I really just echo what Carly said, was in almost all these scenarios, over communicating was the only solution for us.
Great point. Great answer. And I think it brings to one of those pieces that maybe folks aren't aware of, is the amount of funding that you put into each of the communities that you're working with, so that they could develop and implement the evidence-based interventions was significant. Okay, so we have a question in the chat from Zion. Could you talk a little bit about how power was distributed amongst organizations involved in this project, specifically decision-making power? What was the decision-making model you used? And then was it successful? Like, what successes did you have? And so when you think about power, decision-making power could be in a lot of different, happen probably in a lot of different places. So I don't know if you want to walk us through some of the work.
So the question to me seems to be asking about more at the community level in terms of what programs they selected. So that was a community-led process where we had coalitions in each community, ranging from, like 20 to 60, I'm not sure, like, member coalitions from a variety, membership from a variety of sectors that were, committed to this work. And our study team had community teams that helped facilitate the work and the coalitions, but there was also what we call a community coordinator in each community that was hired by the fiscal agent to convene the coalition and help with the decision-making process. The decision-making process is essentially like one of the biggest pieces of the study intervention. So folks would, coalition would look at data, community profiles, landscape analyses to see, what the needs were, what the resources were that existed, what partners were at the table that wanted to, could think of ways to link when they hadn't linked before, what partners weren't at the table that needed to be. And then there was a very sort of prescribed choices that they had to align with those three pillars that I mentioned around OE&D, like naloxone, medications, and safer prescribing. So they had to align to those pieces, and the coalition would put together a plan with a budget, and they would approve it, and then the study team had to review and approve it as well, just to make sure that it aligned with the goals of the study. And sometimes something as simple as a salary was too high, that NIH wouldn't pay for it. So we would have to capture things that would go against NIH policy, as well as scientifically making the best use of the money. In terms of the power, I think the community teams, that was one of their focus, to try to get folks at the table that maybe hadn't been before, and they would have charters for the coalition. So I think like each organization typically only had one vote. So even if you had 3 people at the table from an organization, that didn't mean you got 3 votes.
Diane, did we capture your question? Was there any more to it? You can feel free to come off mute too.
Yeah, that was perfect. If you could talk a little bit about that charter system a little bit more, that's interesting.
I know, I saw Mariel on there. I know where she went. But yeah, so each coalition had to develop a charter, and that was part of the intervention. It was like, one of the check boxes that had a product that had to be done. And it set across, they were all a little bit different, each community, but it just had like rules of engagement, like how often would they meet? Would they have subgroups? How many meetings you need to go to? What was the voting process like? Was it in person? Was it by email? And Mariel's here. So if I missed something, or if you want to add a little bit more specifics, please jump in.
No, I think you really explained it well, Carly. It was up to each of the community coalitions to decide on their decision-making process. And I work in the Plymouth community, and charters were something that was actually new to the group. A lot of folks had worked together before, but they hadn't, made collaborative decisions and voted on, large amounts of money and new programming and stuff. So it was our charter has been revised a lot, I guess I would say. And it looks a little bit different in all the communities, but people for the most part worked really well together. And our voting system is pretty laid back compared to some of the other communities. All of our implementing partners get a vote on how to spend the money. But like Carly said, there might be 3 or 4 or 5 people within an organization that are participating, but they have to come to a consensus before casting their vote.
Great. Thanks, Muriel.
You're
Are there
welcome.
additional questions in the group that folks have about the process? Oh, I have a question in the chat. How do you know when there's full community participation? How is it reflected in the HEAL products? How and from the community perspective?
That's a really good question. Sorry, Carly, what were you going to say?
I think Carly got paused.
Looks like Christina,
Okay.
you threw Carly for a loop. You froze her.
No, I would say a great question. I don't know that was something we measure a lot of things. I'm not sure that was something we ever measured. Did we reach saturation in terms of community participation? So.
Yeah, I think a place where it does come out that we're getting to a little bit more now is when we triangulate different data sources, right? So we look at state level data trends in overdoses, and then we also look at community level data that we collect specific to our strategies. And so, for example, like in certain scenarios where we have strategies where we see that 90% of the demographic population served is white, in a community where the rates of overdoses increasing in Black, Cape Verdean Creole speaking populations, that's how we know, it maybe not necessarily that our coalition isn't representative, but our strategies aren't impacting the population that is representative of the community. So that's a little bit of what we are learning now because we have the data to see that, but that is one way that we unconsciously measure how representative our coalitions and our work is.
Okay.
Yeah, I would say, it that speaks to like it being more of an iterative process and a living process, that we don't say like, I haven't read all the charters, but I'm pretty sure that the coalitions, are open to add new members. There may be a process for becoming a new member, but I'm pretty sure none of them are like closed off, from new members.
Okay. Did you hear anything from like qualitatively from the from the board or the community about like the outreach efforts? Or I was just wondering if there's anything between the lines that you guys heard or saw.
Yeah, I mean,
if not, it's
yeah, I think that our Linda probably knows better, or I don't know if Craig or Marielle, but because Shruti and I are more in the admin sort of aspects, not on the ground as much, but
okay.
I don't know.
Just some thoughts. Yeah. Thanks for
Somebody
doing
else
the
was-
presentation.
Muriel, did you want to add anything there about your experience in terms of bringing folks to the table or increasing participation among your coalition? Not to put you on the spot.
No, yeah, that's fine. Yeah, I mean, I guess a good example is like we just had a new member join our Plymouth Coalition meeting today who's super beneficial. And so I think that that's been the beauty of, facilitating these coalitions is that we're constantly saying, is there anyone we're missing? Is there anyone we want to outreach to? Are these special populations? Like, are we reaching everyone we want to reach? And in Plymouth specifically, it's been a very open slate of come join our meeting, come see what we're doing, come learn about things. And I think that that's from a coalition standpoint, as well as we want some of these new strategies to make sure that they're reaching the right individuals as well.
Okay. So representation. Yeah, that's good.
Yeah.
Right.
And I think really just like giving it back to the community as well, like putting it back on this community coalition as a research staff member. Like, we never want to seem like, you know, we are the experts. So our community teams are constantly learning from the folks in the communities, and kind of, like I said, just like keeping an open book of who else should we be talking to, who else should have a seat at the table. And we do that in a variety of different ways, whether it's, you know, starting different projects or having conversations or, you know, visiting programs, things like that.
Yeah, I just real quick. I was just wondering, Christine, if there was like a little bit more, like what's underneath the question. So I could try
What's
to-
underneath the question?
Yeah, was there like a motivation for that question? Like, I'm just trying to better understand.
Yeah, because I like to hear back. You know, when I do an effort, I like to know if it has, you know, helped the person in a way, or if they feel like more open towards, you know, treatment as a result of being included in the process. You know, that, like, I'm just curious about the effects of outreach, because we're doing the research, right? But we don't know. I just would want to know how
Yeah.
people are taking in efforts. It's
That
important.
does, I think that does actually come, one piece of what we do comes to mind. Our study of our course, we have an implementation science team that's really phenomenal and does a lot of qualitative research. One piece of the research that they do is they do an initial survey and a year after the intervention, another survey to assess the difference in community perception of exactly what you're talking about, stigma related to medications for opioid use disorder, perceptions of carrying naloxone, items like that. So that's really, I think, where we're going to be seeing the measure of that after the study is over.
They also do ethnography of the coalition process. And so they look at the dynamics in the meetings, like who's speaking, who's not speaking, what are the team dynamics. I'm going to jump us forward though, because I'm curious. And if there are other questions, please put them in the chat or come off mute. You're welcome. We want this to be a dialogue. We're lucky to have with us today, Carly and Shruti and their team members. So we want to be able to ask them questions and engage them. One of the questions that had come in earlier that I have here is, were there instances when the planned model wasn't feasible for a particular community? Like, so you were partnering with a community, you had a fiscal agent in mind, but it just didn't make sense, or that there had to be adjustments put in place in some way. And how did that process work?
I can touch on that because that mostly happened early on when we were in wave one. So it's probably about, I don't know, time. I can't believe COVID's been going on for 2 years. So it was before COVID, but I would say that one example in a community where we, the original partner we were trying to work together, but it just didn't work out. And they withdrew from the partnership after realizing that the study was structured in a way that they weren't really accustomed to serving in a fiscal role. And so they weren't comfortable kind of leading the project without having, giving the sort of decision-making process to a coalition rather than their agency. And so we approached another partner that was working with us in the anchor agency. So the two, I think when Shruti showed the chart, there were 2 community health centers. So I think those 2 community health centers are anchor agencies. So they're providing the access to medications for opioid use disorder. And we had initially thought that these would be 2 separate entities in the community, and we really struggled with making the decision of combining them into one entity, because then that was sort of a power thing, giving all of the funds and all more control to one group rather than to 2 in the community. So but when our ideal model didn't work, we had to think of alternates, and we had relationships with these organizations, and we had conversations with them to see if it was something that they could take on extra. So that was one example. And then I think another good example is when Shruti talked about the advanced payments, like that was something that I've never, in a research study done. And so the fact that BMC was willing to create these escrow accounts for some of our organizations so that they would have an advance payment to start the work on was really helpful for sure. Shruti, anything? Yeah.
Yeah, I think that covers everything, Carly. I will say the other big piece that we didn't anticipate, we brought it up a couple times now, was COVID. I think I started like the week before we had to go remote with COVID related concerns. And so that also was an unanticipated burden on a lot of our partners because they're all integral health agencies in their communities. So something that we had to develop was just extreme regular communication with our fiscal agents, like monthly meetings. And a piece of it that we really had to work out, and was a big plug for our finance manager and our finance team on HEAL, is that they have quite literally sat with fiscal agents, filled out invoices with them, and just provided technical assistance like I've never seen before related to finance support in order to make it work for these organizations.
Thank you, Shruti. And Carly, I wonder if you could talk a little bit about that whole trust building process. Like from the beginning, I'm thinking you're able to, how did you forge the relationships with communities? How did you navigate? Because communities are all distinct. They all have their own dynamics, politics, social norms, and you're in 16 different. So one question is, do you see variation in terms of like how you operate in communities based on those norms? If you could give some examples, and then how do you navigate them?
Yeah, I would say that it's also going to be different based on like the role of the person in the study. So my relationship with the community is going to be different than Marielle's relationship with her community, I think, in part because I am not, we just have different roles and different amounts of time, and I might focus my communications with specific people, at the fiscal agent or the cab member, but I think what's been helpful from my perspective in my role is that we started off, trying to identify people that worked in this area in each community by talking to, people that we knew that did work in the community. Like we have a pretty big academic, team of investigators that have done work across the state. So we were able to rely on those folks. We had a good partnership with the Massachusetts Department of Public Health. So we were able to talk to them. That's how we had our, our initial contact. So trying to like have like a warm introduction to an organization was helpful, and being able to like maintain communication through like, we started early, when we were working on the application, invited folks to come to the site visit when NIH came to Boston before COVID, we went out in person and did like our introductory meeting. So I think sort of that personal communication was helpful. I think it's probably helped that we've had really good retention. I mean, we had to hire a lot of people. So, a lot of folks were new when we started, but now I think, people have had time to build relationships over the past year or two. I know, Shruti, do you want to add anything, or we can take next question there?
Yeah, I think everything you said is absolutely right. I think there's also, we're not the first project that a lot of these organizations have worked with through BMC. So they bring that experience, the challenges and the benefits of those experiences with them to their perception of us and our work. So it's definitely in some cases put us in a different starting place in terms of building trust with these organizations. And like Carly said, I think communication has been key in a lot of those instances. And I think something she touched on, which is integral, is that we have different relationships with these organizations that are who we call our community-facing teams. So folks like Marielle. And ultimately, a lot of these times we've had to trust, who I always like to refer them as the person in the room, right? We have to trust their perception of the dynamics and what's going on. And so we rely a lot on our community teams to give us that understanding and that perspective in order to make informed decisions about our community partnerships.
Trust is so important in these cases. So I think it was interesting, and I'm going to go, we have a question in the chat, but I want to just bring up to one point you just mentioned, Shruti, that was about the folks who came before you from BMC. And sometimes, you know, our institutions, I'm a BU, you're a BMC, but our institutions have reputations in communities. And I wonder if you could just talk a little bit more about that and how that impacted your partnering. And then we can jump to Meg's question in the chat.
Yeah, I think especially in some smaller communities, we're seeing a lot of times as the folks from Boston, right? In an area that is like highly supported and has a lot of resources. And if that's not been your own community's experience, that comes with some perceptions, right, that you're working with, and sometimes some distrust in like our willingness and our genuine need for partnership. And so I think a lot of that genuinely just took time in showing that like, we're going to show up, we're going to try to execute the things that you come up with that we think are great ideas, and we're going to support your own goals. And it's just taken time, a lot of that. And I think also we have not been perfect. I think that's just something I'll say outright. And so I think it's gone a long way in moments where we can just say that, and where we can apologize and learn from that mistake and not do it again. I think that's gone a long way with a lot of these communities in terms of building trust.
Great, thank you so much. So Meg's question here is, can you speak to some of the challenges and benefits with cross-community strategies?
Shruti, I think you should take that one. I feel like that's been your specialty.
And tell us what a cross-community strategy is too, in case.
Yes, thank you, Meg. So a cross-community strategy is when a few different communities who oftentimes geographically have shared institutions come together and say, you know, we want to pool our funding on the back end, or HEAL funding, in order to together invest in the strategy that we think is going to be mutually beneficial. So I think a good example of this is when region, two separate communities might have a similar or the same correctional facility. So one of our most at risk or heightened risk for opiate overdose sectors is criminal justice. So folks leaving incarceration. And so that might be an area where a few different communities come together and say, like, we'd love to invest in, you know, a person who can help individuals coming out of these facilities, or a few different communities might come together and say, we're a methadone desert and we need an opioid treatment program. Let's come together and build one. I think there are so many benefits to it, right? Because regionally, I think it speaks volumes to communities wanting to come together around this, as well as the sustainability of these programs when you have that much support behind them. The challenges are that you're dealing with unique communities, and they come with their own dynamics and their own relationships with these sectors. So in particular with criminal justice, our communities have wildly different relationships with their criminal justice departments and organizations within their communities. So sharing and aligning visions and goals is particularly challenging among several different communities. And I think in general, it results in a lot of cooks in the kitchen. So just getting aligned and streamlining communication can be really, really challenging in that sense. And I mean, we've learned that just based on our groupings of rural communities. So we have what we call cluster communities, and what we've learned is that they don't identify as closely with one another as we would have assumed just based on their geography. And so that's been like particularly challenging and just a lesson learned for us along the way.
Great, thank you so much. Great question. Any other questions that folks have? Whoa, a long question just came in. Sorry, that was my reaction.
Oh, sorry, it's not a question.
Do you want to say that out loud? Now that you've typed it all? or I can say it out loud.
Yeah. Sorry. Anyways, yeah, I was just answering the question prior to that one where someone was asking about full engagement, how you know when you have it. I was just saying that I think it's important to frame like community engagement is like it's like planting seeds, right? It's not like you're going to go push a button and then all of a sudden community engagement happens instantly, right? It's a very it's you call it, it's a slow process, right? You know what I mean? And I like to think of it as planting seeds because the seed starts to come out of the shell, the casing, but you can't see it under the ground, right? And this is a very similar way with community engagement. Like as Linda pointed out earlier, trust is huge, and like you're presenting something to people that are traditionally just not trusting, and so it takes a while for them to see it and to see that it's not going to cause harm to them or the people that they care about, which is just it's just a time process. So.
Thank you. Good point. And I wonder, just speaking of time and this time process and building trust, I wonder, you all are doing these 6, like subcontracting in 16 communities on an NIH grant timeline. How has time impacted your work with communities?
Yeah, I think it's probably, I think one thing that you hear is like, this is not a CVPR study, like we have some principles of it and it's community engaged, in certain ways, but it's still a randomized, controlled trial. It's still an NIH funded study. All the, deadlines and auditing issues that reporting that goes along with that. So I think it's probably been rushed, we haven't been able to take as much time as we'd like, either in, building the coalition, before decisions had to be made. I mean, it's great that they continue to grow, but a lot of these decisions were made a long time ago. So I think that, rushing through, I think we've probably, if we've made missteps, people have left the coalition because we, maybe we're taking shortcuts or pushing too hard. So I think it's probably given the research team like this sense of like rush and urgent, and we have to do this and we have to follow this protocol. We have to do it this way, and not as community engaged or as considerate, as it should be. Or, enough back and forth discussion.
Any other thoughts or reflections? We have about 6 minutes left, so I do want to, I'm thinking of time, even though I try to tell myself it's a social construct. I know that we have time, and I appreciate you all spending your time with us this evening. Really fascinating work that's been happening, a lot of lessons. If no one's chiming in, I do have one question related to sustainability. You've made these huge investments in communities, I think how much, $1 million, over $1 million in each of the communities. What are your thoughts on sustainability of some of the work that you've been doing from a fiscal standpoint, like thinking about?
Shruti, do you want to take this one? I know you've been working a lot on that.
Yeah, I think it's a great question. I think firstly, we had to kind of center ourselves with the understanding that sustaining any of the work that's been done will be up to the discretion of the communities. And really what our role is to try to enable how they could do it if they choose to. So I think that was our first grounding step in approaching sustainability, is centering kind of the community choice aspect of it. But what we are trying to do is really push traditional thinking around what sustainability is in regards to fiscal aspects of what we do. So, for example, traditionally speaking, transportation programs have never been seen as sustainable. They're largely grant funded and kind of go from grant to grant. So what we are trying to do is more closely tie it to our cost analyses of addiction consult services or of other hospital-based interventions like bridge clinics. So if we can tie it to appointment data for patients showing up and how that serves a hospital, not just in generating revenue, but also keeping patients out of the ED and lowering ED utilization. and tying it into that analysis, we're able to then make a stronger case for why they should be incorporated in these budgeting processes for hospitals rather than just another line item that's grant funded for a temporary piece of time. So that's the piece of it that we're really trying to focus our energy on as Boston Medical Center, is like, what can we do with the like power and the leverage that we might have in helping to create these like financial models that our communities can show their own hospitals and say, see, it works for hospitals like BMC, it can work for us too. So that's been a huge place where we've been trying to really lean in and support our community partners. I think we have concerns like anyone else that these programs will stop in July. And if they do, we hope it is because it is a choice and not because we couldn't help secure a financial future for them. So the goal is to just have as many conversations to get ahead of it as possible before we run out of time yet again. But it is, like anything else, a little bit of a risk and something that makes us nervous. But as Linda always tells me, we can't always be comfortable. So that's kind of where we're at.
Yeah. I really appreciate the time that you've taken with us this evening just to walk us through. It's so helpful to hear the intentionality with which you've been working with your partners, the trust that you've been developing, and this creative thinking around sustainability, and knowing that the other thing I heard from you is kind of the answers in the group, everywhere from working with your investigators to help build relationships, to working with your communities to help think of having them think about where they want to go with sustainability and what's important for them. So again, we appreciate your time this evening. If there are no final questions, you have some thank yous in the chat. We thank you. We can give you a virtual applause. I can find the button on my reaction. Yes, and thank you for joining us this evening.
Okay. Thanks for having us.
Oh yes, don't forget, next month we are going to hear from Bazola Ojikutu, the Executive Director at the Boston Public Health Commission, who's going to talk about integrating community input into policy and practice with some other community members as well. So let us know, that'll be a good time. You'll get our many emails of reminders, but we are just excited that you joined us and that we are creating a community that is engaged here at BU and BMC. So with that, I'll let you go. We'll be on if you have questions.
Thank you, everyone.
Thank you. All right. We can probably stop recording.
Good idea.
You want us to stay on for a few minutes?
Yeah, we want to thank you.